So I think most of the complications have been managed quite well. So I'll rather stick to my talk on how to avoid problems and complications instead of talking about how to manage them. And when we talk about MIS surgeries, we get stuck to the technique part of it so much that we tend to forget that despite the best technical learnings, even in the most expert hands, the rate of complication rates can range anywhere from 17 to 23%. And the complication may not be necessarily a large one to have a neurological deficit or a vascular injury. It can be as small as wound healing issues or implant loosening or a pseudoarthrosis, which is just an unpleasant deviation from routine outcome in a patient. And this deviation can happen purely because of three coned down reasons. Either there is a wrong indication, a wrongly indicated patient done, a nicely surgery done, but in a wrong indication. Choice of technique. You chose a wrong technique in a well-selected patient. Or you have chosen a nice patient, you have chosen the right technique, but you have executed it poorly. And these three reasons are the only reasons which can give you an unsatisfying outcome. And in MIS tubular surgeries also, something like a very prolonged surgical time resulting into bad results or a frustrated surgeon causing problem due to surgeon's fatigue is very common. In our own paper, we saw that our complication rates are to the tune of 17% over the last 10 years of our experience. I'll show some of them. Inadequate decompression can easily be a cause of unsatisfying result, and it is fairly common in the early part of your learning curve. This is something that has to be avoided at all costs. This is something just not acceptable. Intraoperative neural and dural tears can happen because of various reasons, and iatrogenic pars injuries, facet injuries, and implant-related problems can all happen because of reasons as cited here. Microscope-related issues, C-arm-related issues. Either you are not accomplished to maneuver an implant or instrument or armamentarium, or you are not equipped to have them in your CT. Improper tube docking principles, which is the most important aspect. If you master that, 90% of the problems can easily be averted. And surgical technique related problems again can lead to disastrous issues. So how do we avoid all these things? I think these 7 single liners are the answers that you take home from here, and you'll be able to at least avert 50% of problems. You will be able to avoid these problems in your practice. We will take them one by one. These 7 pointers are a list of extensive research work that we have done in our unit and published as our learning curves in all decompressions, fusions, and management of complications. And all these papers are available as well. So the first pointer is indications, like Dr. Vishal Peshetio rightly mentioned. There is a learning curve to every MIS technique, be it any endoscopy or tubular techniques. You have to climb a particular ladder. And to climb that ladder, the first 50 to 100 cases have to be chosen so meticulously that you need to know and dissect peel by peel the symptoms of the patient, and exact cause of the symptoms have to be known, which you are going to alter as your surgery comes across. It can be a simple radiculopathy because of varied pathologies. You have to find out the exact pathology and deal with it by a correct choice of technique. But the indication has to be correct. And these indications will continue evolving. You cannot be doing a high-grade spondylolisthesis like Dr. Arvind does in his practice, or a cervical like Dr. Rakesh Lohana mentioned, or adjacent segment in your first 100 cases. You have to start with the simplest case, master the technique, master the armamentarium, master the instruments, and only then jump the ladder from a disc to LCS to T-lift to cervical. And believe me, it's one of the most versatile, most dynamic, most expanding horizons of tubular spine surgery. There is nothing that can hold you from doing a tubular tumor resection we just did a couple of days before. Deformities, tumors, infections, all are amenable to tubular spine surgeries. The pathoanatomy has to be understood extremely well. Not every patient has same anatomy. And this is something that we need to prepare very well in advance, because if you try to put a tube there, you need to know all the bony structures in greatest possible detail. Not every patient will have such simplified anatomy there. Some of the patients may have a completely different placement of the pathology, upgraded, down migrated disc, or a facet cyst along with a disc herniation, or a far lateral disc, and your conventional surgery might not work. Your understanding about the anatomy is very important. A deviation from normal anatomy, and you stick to your regular tubular surgery without having recognized those deviations in the spinous process, will lead to your tube sliding away, resulting into inadequate decompression or a facet or a pars injury in your simplest of surgery. Anomalies of nerve roots also has to be identified pre-operatively. Believe me, 90% of your surgery can become successful if you have noted this. Rotation in the vertebral bodies when you are doing decompression is the biggest enemy of any kind of tubular or MIS surgery, and this has to be identified well in advance. To play with a C-arm to get a true AP and lateral is the bare minimum need to avoid these kind of problems there. And remember, all this has to be extrapolated on X-ray because all MIS surgeries are purely C-arm guided procedures, and that's why a true AP, true lateral is very, very important. Now, once you have noted a right indication, once you are equipped with the anatomy, once you have planned your surgery very well, you have to plan your surgery by having all the armamentarium that you're going to require intraoperatively. Believe me, despite in practice for last 17 years, at times I just get stuck for the need of a long cautery tip. If you don't have a long cautery tip to go through the tube, you are wasted there for an hour's time extra. And these preparations can easily be prevented before the surgery. A bipolar which doesn't have a long bayonet can hold you from doing a good hemostasis intraoperatively, resulting into increased blood loss. Sometimes if you don't have a bayoneted nerve root retractor, you may end up leading to neural injury. And all this armamentarium has to be there on the table even before you wash up. And these specific instruments are all available both in the workshops, but you need to get handy to these instruments, prepare them, use them in workshops, and get used to them before you wash up for these surgeries. And all this has to be on the table before you wash up. Absence of one simplest instrument can lead to an unpleasant experience both for the surgeon and the patient. 90% of tubular surgery is all about tube docking. If your tube docking is good, your 50% problems can go away. The right placement of the tube will lead to the pathology directly, and these principles keep changing from pathology to pathology. If a wrong tube docking has happened, it can lead to prolonged surgical time, surgeon fatigue and frustration, resulting into suboptimal decompression, intraoperative struggle, intraoperative bleeding, and facet injury. We have faced it all just because of one simple reason: wrong placement of our tube. So what is the optimal tube docking? Just dock it over the pathological offending agent. And for that you need to know the pathological offending agent. For a decompression, spinolamellar junction is the one, whereas for a T-lip it's a facet, and for a far lateral disc it goes further out in the TP pars junction out there. Remember, these problems also extrapolate if your incision site is not well. And so placement of your tube also decides where your incision is going to place. Imagine you doing a T-lip and your incision is placed medially, you will not be able to resect it well, resulting into a poor result in nerve retraction. Or if you are doing a decompression and you are placed 5 centimeters away from midline, your tube docking, despite good, will be so angulated that you will not be able to do a ipsilateral decompression adequately. And that is why incision placement also has to be very adequate depending on where your tube is going to get docked out there. And this is all retrospective. Some case examples where you have to dock your tube directly on the pathology, and for that exact understanding of the anatomical positioning of the pathology is very, very important. And remember, while placement of your tube is being planned, play along with the anatomy of the patient. Understanding of the rotation and understanding of the angulation of spinous process is very, very important to get the tube placed exactly right there. Understanding of the pathology migration will result into a good angulation of the tubes. Over the top decompression can result into problems if you are not gentle, and that's why try to remain, just 10 more seconds please. You have to remain under the ligamentum flavum, over the ligamentum flavum all the times, because going under the ligamentum flavum, particularly in patients with severe canal stenosis, can result into extensive dural retraction and dural injuries, which has happened to us, resulting into dural tears often, and of course neurological injuries. And that's why over the top decompression, the name suggests over the top, above the ligamentum flavum. So if you are doing counter-sided decompression, do it above the ligamentum flavum, go all the way to the facet on the opposite side, and only then remove the ligamentum flavum if you want to avoid the neural and dural injuries out there. Guide wire is the biggest enemy of a MIS surgeon, and that's why a complete control on this is absolutely mandatory. It can migrate anteriorly, giving gut problems, perforations, vessel injuries, aneurysms, and they, if not problematic today, can become problematic at a later date because of the aneurysms which are not detected immediate post-op. And that's why try to have a complete control. If possible, just take away the guide wire from your set and do guide wireless surgeries. Screw perforation placement can happen either due to medial placement or due to a superior facet violation, and all this happens when we tend to have a good intraosseous and convergent trajectory. Rather, I recommend, if you are a beginner, try to have an end-on view for the lower screws and a convergent entry for the superior screws to have a good osseous placement and to avoid superior facet violations. Cage migration can happen. Try to have a snug fit cage. In last 7 years, I have learned only use expandable cages and do not do interbody fusions if the patient is extremely osteoporotic, because the best snug fit cage will lead to a loosening in no matter of time. And that's why in severely osteoporotic patients, try not to be too aggressive in such patients. And the most important aspect, which my seniors, Dr. Amit Jhala, Dr. Bharat Dave and Dr. Rajshekaran have been emphasizing, problems are known to happen. No matter how well learned you get, no matter how technically sound you are, no matter how good equipped you are bound to face problems in the learning ladder of the MIS surgeries. And that's why whenever you face a problem, stay calm and redo it. And remember one thing, we are all spine surgeons first, and then later we become MIS surgeons. So do not shy away in the early days of your life to convert a MIS surgery into open surgery. At the end of it, it is the good outcome that patient really wants. To summarize, choose the right patient to begin with, plan your surgery in advance, prepare your surgery so well that 90% of the surgery is done on the paper before you really wash up for the surgery. Master your tube docking principles, follow the principles of over-the-stop decompression, and please stay calm when you face such problems. It is completely easy to redo the surgery and convert it to open. Thanks, gentlemen.